So this is a case of an 87-year-old lady who came to our clinic with fatigue and decreased exertional tolerance. Her main past medical history of note was coronary disease. She had had a CABG in the remote past, heart failure with a reduced EF of about 40%, peripheral arterial disease, previous AAA, aortobileal grafting, and a fem-fem bypass, permanent AFib on warfarin, and type 2 diabetes. Her workup was revealing for a very calcified aortic valve with severe leaflet restriction, and she was ultimately diagnosed with low gradient severe AS. So after a heart team approach and appropriate conversations, she was ultimately referred for TAVR. And so this is the post-implant shot after a 26 millimeter Evolute was implanted. Overall, we were pretty satisfied with the positioning, but it was right about this time when she developed some hypotension, and immediately, it was right after the implant, and so with some transient vasopressor support, she seemed to do okay. Blood pressure came up, but then started to decline again to about 60 millimeters of mercury systolic. The TEE was showing us hyperdynamic LV function, so we started to think about what other things could be going on. Tamponade, perforation, paravalvular leak, significant mitral regurg, perforation of the aorta, either ascending or descending, or perhaps something with vascular access. So we kind of went about systematically trying to look at these things, meanwhile, while she was not doing very well. Mitral valve looked okay, no significant effusion. We looked at the TAVR again, traced mild paravalvular leak, but nothing major. We looked down low and couldn't really find much going on with the aorta at the level of the bifurcation, and then looked further down to our femoral access, and you can see the fem-fem bypass there, and everything seemed to look okay. So we came back up and shot an ascending aortic Graham, and if you look closely here on the left side of the image, or the patient's right, you can see some blush there at the end of this clip. So we investigated that further with a subclavian angiogram, and this is what we found. So, as I had mentioned before, she had peripheral arterial disease. The left iliac was basically shut down. So for the second arterial access, we used a right radial approach. This was performed using a Stork wire. And on going up, we had noticed on fluoro that the wire had gone down into the rema, pulled it back, redirected it, got into the aorta, no issues. Patient was doing well throughout the procedure and really didn't have any hemodynamic compromise until right after the valve was implanted or deployed. So at this point, we tried to tamponade it with a balloon. This is a 2.5x15 Trek balloon, and that didn't go so well. Still had some extravasation, reversed heparin, and ultimately we opted for a covered stent. So this is a Graftmaster 2.8x26, and you can still see some faint blush there adjacent to the stent. So we post-dilated this up to 3 millimeters, and with that, we felt like we had a good angiographic outcome. As far as the patient's clinical course, she was on vasopressors for a period of time, epi, phenylephrine. There was significant blood loss into the anterior mediastinum. Our TAVR cases are done with a surgeon and interventionalist in the case, so our surgical colleague felt that he should go ahead with drainage right away, so we did a peristernal thoracotomy in the hybrid room, drained about 2.5 liters, and meanwhile, the patient received about 4 units of PRBCs. Chest tube removed post-op day 6, patient discharged day 12 to a skilled nursing facility. And then in follow-up at 12 months, her symptoms had improved to class 2 symptoms, trace paravalvular regurgitation, and a mean gradient across the valve of about 6 millimeters of mercury. So what are the learning points of a case like this? Seemingly benign wire advancements, soft tip wires, good access, can still produce complications. Vigilance is key. Maintaining a broad differential for hypotension following TAVR and looking at things systematically, even though you may not have any doubts about specific possibilities. And then just having the proper equipment and support to promptly treat and resolve the issue. In our case, we had the covered stents available, the appropriate sizing. We were able to take care of it, and the patient thankfully did okay. Thank you.
So I'll quick question. Did you guys ever think of putting a Vibon versus a graft master in the REMA, actually just placing a large Vibon across the subclavian?
That was not considered, actually. Yeah.
Just
We had talked about bare metal stenting potentially, but then ultimately decided about just going ahead with the graft master.
Yeah.
The other question I have along those lines is, did anybody think about coiling the REMA in that situation?
Yeah, I mean, that could definitely be an option as well. I think just with the expertise that were at hand, that was kind of the decision that we went with, but certainly also a viable option.
And your patient had conscious sedation for the TAVR, or
This was, yeah, it was conscious sedation.
it was conscious? She had no complaints?
Well, no, I mean, she was doing okay throughout the case. Nothing really to suggest that things weren't going our way up until after the valve was deployed. Yeah.